Good morning, and thank you, Dan, for inviting me. And you're always one of my favorite people in my life. So I think we are creating a theme now here with aortic necks and giraffes. As you saw already, aortic neck angulation, it's one of the criteria for hostile neck, and we recognize it early in the endovascular era. In 2007, from the Eurostar data, we found that severe neck angulation for Eurostar was more than 45 degrees. This was associated with 2.3-fold increase of type 1 endoleak. And at the same era, in a different paper, they found that for angulation more than 60 degrees, there was 70% rate of complications perioperatively. And similar trends we have seen all the way, as you see from the papers, up to now, despite the fact that we have been way better in doing these procedures and we have better devices. So aortic neck angulation is defined as the angulation between the axis of the aneurysm and the neck. Comes in many patterns and combinations, as you see there, but it's usually either suprarenal or infrarenal. Infrarenal is the one that causes challenges most of the times for the garden variety endovascular repairs. This slide depicts some of the challenges that we have with angulated neck. This is a 3D reconstruction of a very angulated neck in an aneurysm. You see the length of the neck is 15 millimeters by central line, but only 8 millimeters in the inner curve, and that also affects negatively the total length of the functional neck, which is what counts to have a good seal. Therefore, during a procedure, we really need to elongate this neck and improve the length of the functional leg to have a good seal. Also, when we have an angulated neck, the device might deploy not in a symmetric way, but asymmetric way. That means tilted in an ankle. And the position of the device is, there are many factors that they can affect it. Some of them is the ankle, but also is the position of the wire, what kind of wire you use, what side you use to deliver the device. But when it happens and when the device opens in an ankle, then the sealing zone is not round anymore. It's more like elliptical with larger perimeter. So you have to figure it out early so you can arrange for more oversize, more than 20%, which is what we use usually. Other tools and techniques that we use when we have angulated necks is all kinds of stiff wires. Second stiff wire sometimes at the side of the main body when we deploy it, through and through axis with, again, all kinds of wires, and multiple angulations of the gantry just to get the best one that you don't have parallax and you can see the whole neck. Now, there are many other, when we push the envelope, there are many other adjunctive techniques that we use just to have adequate seal. Already we talk about the endo anchors, which is the most common technique right now, but there are some also historic techniques, like we use Palma's kill technique and endo wedge, and I'll touch a little bit on that. This is when we have the kill technique is the pre-deployment of a very short aortic cuff that's easy to place straight under the renals and then deploying the main device. The endo wedge technique actually was first described by one of my classmates and friend, Dr. Zinos, and usually you can do it only with a Gore device. It's out of the IFU, and basically you just deploy the device while you are advanced against to a balloon in the renal artery. And then there are other techniques. This is one also published by Machamura, where you have a through and through wire from one groin to the other, and then an ankle catheter that keeps the device in the middle of the neck while it gets deployed. This is a very, very angulated neck. It's almost 90 degrees, treated successfully with a Gore device. The operators wasn't mine. This procedure, they use through and through floppy wire from the axillary artery to the femoral artery, a wire into the renal artery, and most importantly, they start the deployment way high, above the renals, above the outer curve of the ankle, just to, and with very fine repositioning, to avoid downward migration of the device if the deployment has started in a lower level. And here there is another successful development. I think, again, it's a EVAR device. The reason I put that here is just to show you that sometimes if you use very stiff wires, linterquist, and thinking that that will straighten the neck, you might cause more deformity of the neck. But regardless, finally, the device was deployed in the right position. This is a patient of mine. It was done 2012 with a GORE device, significant angulation, nice long neck, and the angulation improved with an amplage wire and even more at the end of the procedure. And I want to show you the CAT scan 11 years later, and just to see the remodeling. The neck is completely straight now, but there is an angulation of the right limb, and that the sac, I think now is 4 centimeters, which is actually defined by the distance between the two limbs. This angulation was not there before, but that makes me continue the surveillance for fear that you might have limb separation or even occlusion of the limb. So all the common devices that we use, they have an IFU for infrarenal angulation less than 60 and suprarenal less than 45. Most of us, we have used it out of these instructions. The ones that they have approval for high angulation is the hour fixed device that looks like Anaconda, and the Anaconda device, which is by Terumo. They both are based in ring stent technology. As you see, the hour fixed device has this fish mouth design at the proximal end of the device, which allows the device to seal at the pararenal level of the aorta with some it needs some fine manipulation, the same one that you do for fenestrated grafts, so as the renal arteries, they can come off the sides of the fish mouth. Now, the Anaconda device is fully repositionable. It's also in technology, as I said, and allows custom-made fenestration for more proximal deployment. So this is another patient of mine with very angulated neck that didn't do very well in long run. He had endurance graft initially and 4 anchors only. Usually we recommend now at least 8 anchors for neck to have a good seal. He did well for a while, meaning there was no endoleak, but there was no regression also of the sac, and there was no type 1 endoleak in all the images up to 2020, when he came back with enlargement to 10 centimeters and this major type 1 endoleak. There was no migration. This patient was treated successfully by extending up with a thoracic graft, a periscope to 1 renal, and 2 snorkels. And there's no endoleak. I think that's like a month later or 6 months later CAT scan. And finally, I want you to not take off the table the open repair with angulated necks, especially for young, healthy patients that they have very large aneurysms, that they will not take well a joke if the endovascular procedure fails. This is a patient of mine, 10 centimeters. He underwent bifurcated orthobiiliac graft, and as you can see, had a significant angulation of the neck anteriorly. That makes the endovascular procedure challenging, but makes the open procedure very easy, because that neck, it's easy to put your finger underneath, put an umbilical tape and clamp it. Thank you.